notation on the top left-hand corner that we're being recorded. Hello, everybody. My name is Mercedes Byrne-Klug. I'm with the University of Iowa School of Social Work, and I'm here today with my co-host, Bob Conley, and we are going to present Amy Roberts, who will be giving a talk about the research that she's conducting right now related to nursing home social work. Before I hand the mic over to Bob Conley, I'd just like to familiarize people a little bit with our setup. If you're new to Zoom, please note that at the bottom of the screen, if you run your cursor through the bottom of the screen, there is a chat box, and you are welcome to use the chat box to submit a question at any point. We probably will not interrupt Amy while she's speaking, but at the end of her formal presentation, then we'll go back and look at questions. If you have a question about a specific slide, it's really helpful if you include the slide number, and then Amy can go back to that slide when she addresses your question. The recording of today's presentation will be put on the University of Iowa School of Social Work's website. There's a section of that website for the Nursing Home Social Work Network, and so you can just Google University of Iowa School of Social Work nursing home, and you'll probably get right to it. It's a section on webinars. And so after today's session, the recording will be posted there. And right now, Amy's PowerPoint is there. So if you happen to be joining us by phone and you want to follow along on print or on your screen, you can go to the University of Iowa School of Social Work's Nursing Home Social Work section of the website, and Amy's PowerPoint is already there. All right, Bob, why don't you introduce yourself, please, and then tell us a little bit more about the lineup for the fall.
Okay, so my name is Bob Conley. I'm retired from CMS. I worked there as a consultant and as an analyst for about 27 years, and before that I worked for 14 years in hospital social work. I retired in 2008, and as one of my last events was we created this CMS social work connection, because there are many social workers that work at CMS and nurses that work in psychosocial research, and we found from 2008 on we would have these webinars which are called the long-term services and support social work webinars. So we send out an invitation to over 100 people who have been part of us over the years, and we try and find topics that really deal with long-term care, deal with psychosocial care, deal with discharge planning. And today we're very lucky to have Amy Roberts, who will be giving us information on her research from the Miami University School of Family Science and Social Work. As Merce said, we've tried to set up a lineup for the rest of the year that will give you what we think are really some cutting-edge information. On October 27th, from noon Eastern to 1 p.m., we're going to have a program on health disparities. We have two speakers who have national reputation. First is Sonia Bowen, and she's going to talk about research that's being done and supported on disparities called the CMS's SNF Health Equity Initiatives. And the purpose of that is to increase provision of culturally and linguistically appropriate care in nursing homes to serve the vulnerable and linguistically diverse population. She's going to share the podium with Jim Zabora, who is working at Johns Hopkins in cancer research, and he's going to discuss what I think is very interesting, the health disparities work that they're doing in Baltimore, whereas Johns Hopkins is a universally known institution not too far, probably 10 miles from it, is a minority community that has some of the highest rates of breast cancer and prostate cancer. So Jim is out doing community research. So mark your calendar for October 27th from 12 to 1. On November 10th from noon to 1 Eastern, Nancy Wilson is going to be speaking on a topic called Exploring Primary Outcomes of Calmer Life, Community-Based Intervention for Late Life Anxiety in Underserved Communities. And this is really, I think, again, a cutting-edge research. Baylor University, where she's been, or Baylor School of Medicine, has done research on cognitive behavioral therapy, trying to see how we can drill it down to be able to compare BSWs and PhD psychologists using this tool to reduce anxiety in older adults. They've shown that that's comparable, and now this study is working in an underserved community where they're training community workers in cognitive behavioral therapy to work within their church community to try and help chronically ill elders deal with anxiety and thereby reduce rehospitalization and emergency. So again, I think this is very promising, because as we're needing to have more elders, more people working in aging, if we can get tools to drill to lower level staff, we'll be able to serve more people, and particularly in underserved community. So we look forward, we'll be sending out notices on these, but today we're looking forward to Amy, so I'll turn it over to you, Amy.
Thank you, Bob, and thank you, Merce. I really, really wish to thank you both for inviting me to share some of my research with you both. And for all of you who have joined the call, thank you so much for being with us here today. For those of you who might be listening to this in the form of a recording, I wanted to mention that you can find my contact information on the last slide, and you are welcome to send me an email. I'm eager to receive your comments, your questions, and your recommendations for future research. So, by way of introductions, my name is Amy Roberts, and I'm an assistant professor in the Department of Family Science and Social Work. I'm a social worker by training, and I'm also a research fellow at the Scripps Gerontology Center here at Miami University. The focus of my talk today will really be on social service staffing and nursing home quality outcomes. And so I'm looking forward to sharing this with you. By way of our agenda, I'd like to start by giving you a little bit of a background about why I feel strongly about the need to study social service staff in nursing homes, just to lay the groundwork to make sure that everyone on the call is aware of some of the research that has been done in this area already, and again, to really share with you why I am interested in this line of research. Then I'll be presenting two studies that I have completed with my colleague, John Bobliss. John is an associate professor of economics at Miami University, and we've been working together on studying staffing in nursing homes with a particular interest in social service staffing. In my first study that I'll be presenting, I will share information with you about nationally what is happening in terms of the staffing of social service departments across the United States. And this will give us a big picture look about the different configurations of staffing patterns of social service departments. We'll also consider a predictive model that will help to explain some of the reasons why different nursing homes may go with different staffing patterns. We're going to be specifically looking at some of the structural and contextual factors that drive some of the decision-making in social service staffing. And then we're going to take a little bit more of a broader approach to examining staffing in study 2 across a range of disciplines. So we will be examining staffing that's related to nursing, social services, activities, and food services and housekeeping as well. Our analyses in Study 2 will identify which departments have the biggest impact in reducing the number of deficiencies and the severity of deficiency scores that facilities receive during their annual recertification process. And so we'll talk more about that in the study, but ultimately, I will be sharing some practical recommendations with you about the staffing decisions and various departments that have the biggest impact in reducing deficiency outcomes. And I also will be approaching this from a cost-effective standpoint. So we're looking for information that I can share with you around a variety of different departments and their impact in the most cost-effective way. And my question in the back of my mind is it time to invest in social services? So I'll keep you on the edge of your seats to find out more about that study. Towards the end of the webinar today, there'll be an interactive question and answer session. And here I'd love to hear your comments, questions, and suggestions for future research. And again, if you are connecting to this webinar in its recorded version, you're welcome to send me an email. So by way of sharing a little bit more information with you about the importance of this topic, probably all of you on this call realize that social service staff are uniquely responsible for providing psychosocial care. And it's this type of care, the psychosocial care, that really supports residents' physical and mental health to promote the highest possible quality of life. Psychosocial services are really designed to enhance the mental, social, and emotional well-being of nursing home residents as they deal with a number of stressors that can relate to their own health, stressors related to living in a specific institutional care environment, or other aspects of life that can negatively affect quality of life. These services promote residents' dignity and self-worth. They provide strategies for individuals to become socially engaged or remain socially engaged, and they can also reduce depressive symptoms. So residents are dealing with a number of stressors, including adjusting to living to a new institutional care environment, adapting to new levels of functional impairment, as well as coping with mental health issues in many cases, such as depression and dementia. Another reason that underscores the importance of this topic is that research has documented a need to improve psychosocial care in nursing homes. Most of the residents do have at least one psychosocial care need. However, a national review does find gaps in having these needs met within nursing homes. In order to meet psychosocial care needs, social service staff are involved in a wide range of activities. These include, but are not limited to, completing the psychosocial assessments at the time of movement and ongoing care planning, providing emotional support and interventions for residents and their family members to enhance their coping skills, and also promoting individual decision-making to facilitate maximum choice and preferences in a manner that's consistent with person-centered care ideals, and finally, assisting with transitions in care, whether we're talking about making referrals or discharge planning as well. In terms of what we know already about this topic, I do want to acknowledge that scholars have noted that there is a considerable variability in the staffing of social service departments in nursing homes, that individuals who take jobs in social services have differences in their educational preparedness, and many have called for clearly differentiating roles of a social worker, a professional social worker, from paraprofessionals or other social service staff that we'll talk about more in a moment. And finally, we're hoping that we can use this information to really pursue a line of research in order to figure out how we can maximize the effect of social services in a positive way to help achieve the highest quality of life for nursing home residents possible. So what I'd like to do at this time is I will turn off my webcam so that we can focus on the slides. Very good. So in our first study, I'm going to be talking about the variation that takes place in social service staffing in nursing homes. And I did want to note that I provided information about the full citation on this webpage if you would like to look up the article that's been published in Health and Social Work. So this study had two main research questions. First, how are social service departments organized in nursing homes? And second, what structural characteristics of nursing homes and other macro-focused contextual factors explain the differences in these social service staffing patterns? And in this study, we used CASPAR data. CASPAR data is the CMS Certification and Survey Provider Enhanced Reports. It's the most comprehensive source of descriptive facility-level information on Medicare and Medicaid certified nursing homes in the United States. And it's collected and also validated on-site by state surveyors about once a year. CASPAR is a very rich data source that includes information on staffing and other facility characteristics, along with the resident population that's being served within the facility. These analyses use a regression model to examine some of the effects of the contextual and structural factors in the nursing home on determining who is likely to hire social workers and the staffing patterns in social service departments and nursing homes. And we use data from CASPAR surveys for our sample for the lower 48 states, which was about 60,000 observations. So CASPAR tracks two types of social service staff that I'll give you an overview of briefly. First, CASPAR defines a qualified social worker broadly to include an individual with a bachelor's degree in social work or a human services field with at least 1 year of supervised social work experience in a healthcare setting working with older adults. However, I should say as well that the NASW, the National Association of Social Workers, specifies that nursing home social workers should be meeting additional criteria, such as obtaining at least a bachelor's degree from an accredited school of social work, 2 years of postgraduate experience, and state licensing or credentialing by NASW. And social work training in general involves an accredited curriculum, an extensive field placement to develop competencies for practice, adherence to a code of ethics, and completion of continuing education. But we also have another type of social service staff that allow us to reflect others who do not have a bachelor's degree in a human services field but are responsible for providing some medical social services to residents. So what we are anticipating that from a policy perspective, our federal regulations require all nursing homes with 121 beds or more to employ a full-time qualified social worker as defined in number 1. Therefore, larger nursing homes with more than 120 beds are likely to employ only qualified social workers or teams of social workers with other social service staff, which we refer to as interprofessional team. But in contrast, smaller nursing homes with 120 beds or less are required to provide medically related social services at the same quality level, but they're not federally mandated to employ a full-time qualified social worker. So with these two categories, the qualified social worker and the other social service staff, we were able to examine kind of the commonality of hiring qualified social workers as well as other social service staff, both as individual categories, but then we also combine them together to examine the interprofessional team idea. In terms of our descriptive findings, we find that a large percentage of nursing homes in the United States have hired qualified social workers, about 89%, whereas about 11% has not hired a QSW. But if we look to the right, the percentage of nursing homes use paraprofessionals is quite large. About 60% of the nursing homes in the United States do rely on medically related social services provided by paraprofessionals. In this next slide, this reveals really the gist of the social service staffing patterns that we see in the United States. So for about 42% of the nursing homes in the United States, they hire their social service departments to be comprised of only qualified social workers, whereas about 10.5% hire only paraprofessionals to be part of the social service department. However, this green section on the left-hand side of the slide indicates that interprofessional teams are quite common. Almost 50%, or nearly half of all nursing homes, provide social services through this interprofessional team model. So we should say as well that both qualified social workers and paraprofessionals make important contributions to social service departments. Qualified social workers do in general have higher education, role preparedness, salary, and licensure requirements compared to the paraprofessionals. In this slide, we examined and report out some information about factors that affect social service staffing patterns across the country. And our regression analyses found that regulatory factors in terms of state and federal regulations were a strong determinant of social service staffing patterns. Larger nursing homes were definitely more likely to hire qualified social workers and use interprofessional teams to provide social services. But in addition to the regulatory factors, contextual factors such as rurality contributed to differences in social service staffing patterns. Rural nursing homes were more likely to hire paraprofessionals and less likely to hire qualified social workers. And in addition to that, some structural factors about what is occurring within the nursing home and the financial resources to support the structure of the nursing home also mattered. The facilities that were affiliated with a continuing care retirement community or hospitals were more likely to hire qualified social workers, along with facilities owned by nonprofit organizations. Qualified social workers were also associated with more profitable reimbursement payer sources. But interprofessional teams were much more common in situations where facilities were focused on short-term stays or rehabilitation. Surprisingly, this analysis did not show any support for resident characteristics being associated with different social service staffing patterns. And the resident characteristics that we included in the model included the acuity level of the residents in the facility, the percentage of residents that had dementia, depression, or psychiatric illness, or developmental disability. So from this study, I'd like to share three main implications, and the first is related to workforce development. Because we know that the educational preparedness for this role varies, and that in almost half of all nursing homes, qualified social workers and paraprofessionals are working together in interprofessional teams, it suggests that qualified social workers may be in a position to educate, mentor, and supervise coworkers who may not have a background in social work or specialized training in gerontology. And I did want to mention that there are some free resources available online at CSWE Gero Ed Center, and that's the Council on Social Work Education Gero Ed Center, that offers many tools for faculty, students, and practitioners to build skills and competencies in gerontological social work practice. But I do feel as well that there's a need for future research to consider how these teams can work together most effectively and really shape the optimal combination of staff education and skills and responsibilities to deliver high-quality psychosocial care. The other point that I would like to make about the implications of this study is the power of the federal and state regulations. As we can see, they had a huge effect on determining the patterns of staffing for social service departments. And these regulations are driven by the size of the facility, not the level of psychosocial need or the caseload considerations of practitioners. So going forward, these stricter regulations and guidelines may be the most effective option for improving psychosocial support and other quality guidelines. And I believe that the needs of residents should have some effect on staffing patterns and levels. The National Association of Social Workers does have standards of practice in long-term care, and these regulations should be consistent with or brought more in line with these standards. And finally, there are structural and contextual factors that matter in terms of making staffing decisions in these departments. And it's important to identify these as high-need areas to ensure proper psychosocial care. These high-need areas might include rural nursing homes or facilities that have higher resident needs. And our study suggests that paraprofessionals may be expected to provide all psychosocial care as well in smaller facilities. And this is especially true for those that are located in rural areas. So as we move along to the second study, since we've completed an overview of the social service staffing patterns across the United States, we will next focus on the relationship between staffing levels from various departments within a nursing home and quality outcomes. Here, we examine the departments within a nursing home holistically to test the relative effectiveness of each department in reducing the number of regulatory deficiencies and the severity of the deficiency scores. After we determine which departments have the biggest impact in improving nursing home quality, then cost effectiveness will be considered. So the practical advice that we'll be able to provide will allow us to make recommendations about the types of investments that are likely to have the largest impact in the most cost-effective way. So in terms of some background on this topic, we know that nursing homes must employ a variety of different types of staff in order to provide proper care to residents. Some of this care relates to nursing and direct care that is given to individuals. Some of it is more ancillary in terms of providing dietary services and food to individuals that are nursing home residents. But there is a variety of departments that are designed to function together to support the quality of life and high quality of care of individuals in nursing home facilities. We also know that there are some minimum staffing regulations in place that do impact nursing home choice about the staffing levels. So for example, there are minimum direct care and licensed nurse staffing levels that are based on ratios of staff to residents. And also, there is a federal regulation that requires a qualified social worker to be hired in nursing homes that are larger in size. But in terms of the academic literature, most of the attention has been devoted to nurses, and higher nurse staffing levels has been associated with better quality. But other types of staff may also impact the quality of care and quality of life. Some of this work has examined social service staff and found that higher levels of staff may affect quality of life and may actually enhance quality of life through decreasing the number of deficiencies. But to our knowledge, no work or little work has been done on a variety of departments from a very holistic standpoint that includes all of the majority of different departments that touch the lives of residents. So the purpose of this study is to really look from a comparative perspective to holistically examine how a modest increase in staffing within a specific department could in fact improve quality. And so we'll be examining the different types of nursing home staff with particular attention to investments in a certain type of staff, which may actually produce a more cost-effective strategy for improving quality for nursing homes that we know are dealing with very constrained budgets in this environment. So in terms of our outcomes, we used the nursing home deficiency citations from the CASPAR dataset to examine the construct of quality. And so the number of deficiency citations received by each nursing home, it was collected, and we looked at the number of deficiency citations initially, and then we also broke down the deficiencies that were endorsed by categories of quality of care, quality of life, and administration. And we also included, in addition to the number of deficiency citations, the deficiency score, which accounts for the number of deficiencies that are weighted by the severity and the scope of their impact in the resident population within the nursing home. And this outcome is very relevant to providers because the deficiency scores are used to calculate ratings on the nursing home Compare 5-star rating system. So lower deficiency scores are associated with more stars, better ratings of higher quality. In terms of our staffing measures, we drew staffing variables from CASPAR and converted the staffing levels to hours per resident day to capture the amount of staff time available for each resident in the facility. And the types of staff that we examined specifically are nurses with administrative duties, direct care nurses, including registered nurses, licensed practical nurses, and certified nursing assistants, social services, activities, and food services, and housekeeping. In terms of our covariates or control variables in the model, we included facility-level measures of the structure, financial resources, other staffing resources, and resident characteristics. So again, we used the data source of OSCAR and CASPAR over a period of time between 1998 to the first quarter of 2016. We ran regression models with the nursing home facility as being the unit of analysis. And that resulted in a sample of freestanding nursing homes in the United States and the District of Columbia with at least 10 beds and at least 2 observations over the study period. And that led us to a sample of about 237,000 inspections in about 16,000 facilities. So to give us a sense of how nursing home staffing levels have potentially changed over time, I'd like to draw your attention to some of these different categories at the bottom of different departments. So here we see administrative RNs, registered nurses, licensed practical nurse, certified nurse aide, social services, activities, food service, and housekeeping or food and housekeeping. And so what you can see from this graph is that in some of these categories of nurses, you can see that there has been some change in terms of an increase in staffing between 1998 and 2016. But if we look at some of the social services, for example, or activities, you see less of a change over that time frame. So I just wanted to point out the relative low levels of social service and activity staffing relative to the other departments.
This place, Amy's checking on her.
Hi, so I'm going to continue on unless someone has a question. Okay, great. So this slide and trends and deficiency outcomes on slide 20 shows the quarterly average of deficiency outcomes over the same time frame. So as you can see, it looks like the deficiencies are, the number of deficiencies appear in this top line, this dashed black line, and the score appears in this gray line below. There seems to be somewhat of consistency between the average deficiency outcomes between 1998 and 2016. So in slide 21, I'd like to share with you some of our findings about the relationship between the number of deficiencies, the deficiency scores, and nursing home staffing levels. So just to orient you to the table, in the left-hand side we have our variables in terms of our sample over this time. And over the average amount of time, what we see is that the average facility had 6.34 deficiencies, and the points, they're calculated based on the scope and severity of 43.6 points. The hours per resident day of staffing show our staffing variables by the categories that I presented. And then we also have these columns at the top that show us the number of deficiencies and the deficiency score. And in the number and points column, Here we go. This shows us how much does the outcome change if you increase staffing by 1 hour per resident day. So what we find from this is that for social services, increasing the amount of social services by 1 hour per resident day results in 1.395 fewer deficiencies, which reduces the number of deficiencies by about 24%. If we look over here for the deficiency score, we see that increasing social services would result in a 40.2% reduction. One of the other trends I wanted to point out, to be sure to point out, is that all of these staffing variables do improve quality for the most part. So except for some of the food service and housekeeping. So for increasing nurse staff as well as social services and activities, we do see that if staffing is increased, that quality will increase as well. But what this does in terms of giving us some comparative perspective is to allow us to determine the different effects that we see between the different departments in terms of reducing the number of deficiencies and the deficiency score. And after comparing these values, you can see that social services has the biggest effect in reducing the total number of deficiencies as well as the deficiency score overall. So again, because all of the coefficient estimates that are significant are negative, it indicates that higher staffing levels are associated with better quality outcomes. But in terms of the relative size, the largest reductions are for social services, followed by administrative registered nurses, making the biggest reduction in both the number and the deficiency score. But what we wanted to do as well is to kind of separate out some of the deficiency citations that were attributed to quality of life domains as well as quality of care domains. So whereas the previous slide really looked at the overall view, slide 22 allows us to understand more about how staffing in terms of these different departments may impact the number of deficiencies and the deficiency score that's related to quality of life. So again, each type of staff focuses on the diverse needs of residents, and so these different types of staff may have different impacts on various aspects of care. When we break down the deficiencies by quality of life, and in the next slide we'll consider quality of care, we find that social service staff are most effective with reducing the number of deficiencies and the deficiency score in the quality of life category, followed by administrative RNs and then activity staff. So if you look at the value here as well as here, you can see that this is the largest value, and administrative RNs is the next largest value in terms of impact. And in fact, the administrative registered nurses actually do have a little bit of a larger impact in reducing the deficiency score overall in the quality of life category. If we ask the same question when we examine the relationship between quality of care and nursing home staffing, we also see that administered registered nurses and social service staff have the largest effect on the number of and deficiency scores for the quality of care deficiencies. So here we see administrative registered nurses and social service staff. Again, both of these types of staff having a much larger effect in reducing the number of deficiencies related to quality of care and the severity of the deficiency score. This leads us to conclude that administrative RNs and social service staff are among the most effective at improving deficiency outcomes. However, it might be more economical to hire staff associated with smaller improvements in deficiency outcomes, but are more affordable for a facility. So this question really gets to the heart of the issue that many providers experience of having a very limited amount of money to invest in addition to what they're already paying for staffing. So our question in slide 24 has to do with a modest investment, simply adding a little bit more money per hour in a 100-bed resident facility. So essentially what we are asking is for the question that relates to this is really about how can we make the most efficient use of this investment if a facility only has $100 more per hour to invest to improve quality. So table 5 below reports the percentage reduction in the deficiency measures if a facility invested an additional $100 per hour for each type of staff. So to calculate this, we used national hourly wages that were obtained from the Bureau of Labor Statistics to determine the number of additional staff that could be hired for $100 per hour, assuming the only cost of employing staff is the wages and without fringe benefits. So we used information on staffing levels that were converted to hours per resident day for the typical facility and the coefficient estimates from the tables in the previous models to understand more about the percentage change in the number of deficiency citations and the deficiency score associated with a $100 per hour investment in each type of staff. So as you can see, that we have the national hourly wages here provided, and the relative effect of the reduction in number of deficiencies and deficiency score. So for deficiencies, we can see that that social service staff have the biggest effect, followed by activity staff. For the total deficiencies, if we look at the quality of care, we can also see some of the same trends in that social service staff are more cost effective, but they're also followed by activity staff and administrative registered nurses as well. And for the quality of life domain as well, we see similar trends with, again, social service staff and activity staff really having a big impact on reducing the percentage reduction in the number of deficiencies and the deficiency score. So our major findings from this study support a relationship between higher staffing levels and fewer deficiency citations and lower deficiency scores overall. And advocates for nursing home quality have argued that in general, staffing levels in nursing homes are too low, even after adjusting for residents' level of need. We found that while the administrative registered nurses had one of the largest effects, they also have a high hourly rate. So among nursing staff, an additional hour per resident day of a registered nurse was found to have an effect that's almost 5 times the size of a certified nursing assistant. An hour per resident day of social service staffing resulted in the largest reduction in deficiency outcomes, but after we adjust for differences in wages, the activity staffing was nearly as cost-effective as social service staff. And one of the main points I hope that you can take away from this message as well is that social service and activity staff are over 2 to 3 times more cost-effective than increasing nursing staffing without administrative duties, depending on which measure was examined. So this leads me to recommend that facilities really consider investing in the departments that are shown to have the largest effect in decreasing the total number of deficiency citations and reducing the deficiency score. So we recommend that providers consider increased staffing for the following types of staff: social services, activities, and administrative registered nurses. The least expensive strategy to improve deficiency outcomes involves increasing social service staff and/or activity staff. Again, and to tie this back to some of our discussions earlier, these types of staff really are specifically called to provide psychosocial care in terms of the social service departments, as well as help residents engage in meaningful social activity as well. So in terms of our policy recommendations, I think that this study provides further evidence of the need for social services to consider minimum staffing ratios for social service and activity staff by providing some guidelines about what should the minimum level look like. can we help to arrive at a more appropriate level that would allow for the social service staff to provide high quality psychosocial care. And this idea is certainly consistent with how the nursing staff and direct care nursing ratios have operated. And again, as we've seen, that the staffing in the different types of nursing lines of the nursing department actually has increased considerably from 1998 to 2016. We have not seen the same sorts of trends from social services and activity staff. There has been some suggestions about what these staffing levels should be, and these include resident characteristics and the level of psychosocial care needed that should be taken into account to determine what a realistic caseload would be for a practitioner. And again, additional work is needed to determine the implications of the social service staff composition, because in study 2, we took a more broad approach of looking at who is staffing these different departments, and we were not able to compare differences between educational preparedness for various roles. These are strictly looking at staffing levels. So I've provided some references for you to review, and that have helped to inform some of my work and have been cited in this study. Thank you so much for your attention, and I'm hoping at this point we can transition back to a more interactive question and answer session with Merce and Bob. And I hope that you will feel comfortable sending me an email if you have any questions or comments or recommendations to share.
I have unmuted everybody, so even our guests. So if you are a guest and you prefer to be muted, please mute yourself back again, because right now everybody is unmuted. Since we are a small group, we can go ahead and unmute everybody and just have a discussion. So first of all, thank you all for joining us today. Everybody's unmuted now, except a couple people have remuted themselves, which is fine. There's Amy. Amy, you gave an absolutely fantastic presentation, and I love the way that you use data that are already available. This is a secondary analysis of data that are already collected by the federal government, and you and your colleagues were really effective in making some meaning out of all this information that can give us some direction on how to go forward.
Thank you.
So absolutely excellent presentation. And I'll start us off while people are thinking of their questions. And if you don't feel comfortable speaking, go ahead and put it in the chat box, and we'll be checking the chat box too for questions. When you talk about the administrative RN and the administrative RN's role in reducing deficiencies, and are we talking about the RN who is mostly doing the MDS? Is that the main responsibilities of that person?
You know what? I'm not entirely sure. My understanding is that that person would have more care coordination responsibilities and management and oversight of the individuals that are involved in some of the direct care. But I noticed Bob is responding. Maybe Bob has a clear description of the responsibilities of the administrative RN.
Well, I just know it wouldn't be the MDS nurse, because sometimes she or he does coordination, but what I think you're really talking about is problems in healthcare, mental health, psychosocial care, that there's more administrative staff to work with the team. That's my sense of having looked at it at a national level. But I wonder if there's anybody on the phone who's actually working in care that could better describe it from a bedside manner.
Oh, that's all right. It was I was just a little curious. Are there any questions from the group? Would anybody like to ask a question? There's no way to really raise your hand, so just go ahead and start speaking if you have a question.
Can you guys hear me?
Yes.
It's Nancy Cussall. How are you?
Hi, Nancy.
Amy, this was great. This got to some of the things that we talked about last November around, making a case for, the cost effectiveness of social service staffing. And as you said, the piece that's missing and kind of the next steps, I would think, would be to figure out some way to look at education or training levels. Is there available data that would look at that, or is that something that would have to be collected as primary data?
So I think that's an excellent question, and I'm all ears. I know that we are somewhat limited by the categories of that are set up within the CASPAR data, and I am not familiar with a lot of other nationally representative data sources that might be able to answer that question, aside from the research that Dr. Brun-Klug has done and some of the data that she has collected. So, Merce, would you like to speak to that a little bit, or share?
Could you reword the question, please?
The question was about kind of if the next steps in the analysis are, if the findings are that social service staffing is the most efficient use of cost effectiveness, but the next step is finding out the educational levels of those social service staff. Is there any data that exists to look at educational levels of social service staffing, or is it more of the things that you've collected, the primary data, to create that?
As far as I know, the data that we collected here from the University of Iowa is the only nationally representative data of nursing homes of all sizes, all number of beds, where we got detailed information about the educational preparedness of the social service staff members. And those data are now 10 years old, so it's time to repeat that study. What repeating that study won't answer, though, is a very important question that you're hinting toward, I think, and that is we need two things. Actually three things. We need well-prepared and highly motivated social workers, but they also deserve a realistic ratio, because the best prepared social worker in the world is not going to be able to meet the psychosocial needs of 150 frail elders and or persons with disabilities. So we both need somebody who's well prepared and highly motivated and supported, and then realistic ratios. We also need to have these social workers embedded in a nursing home system that has a strong team, because the nursing home is only as strong as the weakest link. And that's a whole other area of research that I think we need, is not just looking at one profession, but looking at the team. So what combination of preparedness and ratio provides the best quality care for America's nursing home residents and families? And right now we don't know.
So I see a comment from Chris saying, absolutely, Merce, well said on all counts.
Oh, thanks. Another thing that came out of your work, Amy, that has really impressed me is the need for social workers to be working more with activities personnel. Mm-hmm. I think we've looked a lot at nursing, which is important, but we haven't worked as closely or as well with the activities professions. I've looked at the federal regulations. I'm working with a group of students right now. We're comparing the state administrative codes on activity personnel, and the whole structure is very different than how social work qualifications are set up. But as is the case with the social work, the federal regulations are not in keeping with the National Trade Organization's requirements of an activities director. Same as we see the parallel structure with social work, that the federal government's requirements for social workers in a nursing home setting are not consistent with what the field of social work says.
Mm-hmm. Absolutely. And if this information can be used to make some changes. If anyone on the call has ideas about how we can use this information to be able to say, nursing home providers really should be looking at staffing at a higher level, social services, activity staff, to have a real impact on the number of deficiencies as well as the severity and scope of the deficiency score. How do we get that message out, or how do we share that with the right groups of people so that, if the policies are not as easily modified, that we have a way of sharing that with providers?
I think you should offer to present at the 2 trade associations' national meetings.
Okay.
I think they would really be, the way you framed your study is so elegant and actually addresses the question that they want to know. If they had extra resources, where are they going to get the biggest bang for their buck? And the way you set up your study, that's the question you answered. And so I'm the Leading Age and the American Healthcare Association, they both have annual meetings, and they also have state meetings. I would look into their call for papers, or actually call up the associations and share your paper with them, because you're absolutely right. We may not be able to make changes at the federal regs level at this point, but when it's clear to the nursing home administrators that it's in their own best interest to, and in their residents' interest to increase the staffing levels, I think that will make some difference. Other ideas or thoughts or questions from people?
Yeah, having worked at CMS for as long as I did, the criticism with social work was that there was no data, that people were giving anecdotal information. This is real data. This is CMS's CASPAR data. They're spending millions of dollars to get it. So there's a validity to this process. There may be some questions of how you did it and that kind of thing, but I think you're really saying that having a higher level of social service, perhaps activities even at a low level, will impact in quality of life, quality of care, that administrative nursings really affect quality of life, quality of care. Those are important issues, and so I know Robin Stone, who's at Leading Age. I'll send you her contact information. Maybe you want to send her your study and that kind of thing. I have some other people at American Healthcare Association that I think you might want to deal with it. You may even want to get involved with the people who do CASPAR and the people who write the regs, because the question that I have is, if you found this without really competency data, which would be the other important thing that's being put in the regs, and we're asking in the new regs to do much more complexity of care in terms of mental health and behavioral health and discharge planning, I think it might be timely to bring that forward. I don't know if anybody's going to bring you in, because it leans to spending more money, but it's the first time I've seen someone that's done cost effectiveness and measuring staffing, which everyone in the nursing home community knows is important. And the other thing is, a lot of the staffing is now much better than it used to be, because they're using the actual records of staffing, not anecdotally how many things the surveyor did. So I'll get back to you offline with that, but I do think it's meaningful. The other thing I've always wanted to look at is that in the VA, they have all MSWs, and I wondered if the same algorithms would be used when they do their surveys to look at whether the same regression could be looked at. I don't know, but that would be something that Kelsey Simon you might want to talk to about.
I think that sounds like a great idea. Maybe the potential of a comparative study. I know that MERS has identified, the different regulations that states have that vary quite a bit, that they can either require a master's level social worker or relax some of those requirements under certain circumstances. So being able to identify an entire system and consider some of the resident characteristics as well, it would be fabulous.
Yeah. So, but I think it's great. Congratulations to you and your colleagues.
Thank you. Thank you.
Are there any other questions or comments? I see something in the chat box from Chris Herman. She's thanking Amy for the presentation, and she looks forward to reading the journal article.
Great.
She's going to be on the lookout for ways to incorporate your information and findings into NASW comments to CMS. So wonderful.
Thank you.
Anybody else have a question or comment? Well, Amy, thank you again so much for all the preparation you put into this presentation, and then all the work into analyzing the data and packaging the data in such a straightforward way so that we consumers can pick up your findings and take them and try to make some use of them. This recording will be posted on the University of Iowa School of Social Work's website, and we look forward to seeing you later on in the fall.
Great.
All right.
Thank you.